executive member of the ICB. I'd like to welcome everybody to the meeting today, and I will be chairing the meeting. As I think most people will be aware, we're currently on the third day of industrial action being held by junior doctors. Because of the need for a number of our board members to be present on their hospital sites during this action, we made the decision at the end of last week to move the meeting virtually. I would like to thank everybody for their understanding in making this move and apologise for any inconvenience this has caused. Can I remind everybody that the meeting is being broadcast online and recorded. The recording will be uploaded onto the ICB website after the meeting. A version with British Sign Language will also be produced and uploaded. Can members please remember to use the hand button if they wish to ask a question or contribute to the discussion, and to remain on mute if you are not speaking. Can I also remind everyone that this is a meeting which is being held in public, not a public meeting. We will do our best as always to avoid jargon and acronyms, but a glossary of terms is available on the ICB website if people need it. Unfortunately, because we've moved to a virtual meeting today, we cannot take any live questions from members of the public as we would do normally. But the public has had the opportunity to submit questions in writing before the meeting. In terms of apologies for today's meeting, we've received two apologies from James Blythe, Place Member for Sutton, and John Byrne, Executive Medical Director. With no further apologies, the meeting is quorate. Moving on to item 2 on the agenda. So we have a register of declared interests included in the pack of papers. Members are asked to declare any additional interests not already on the register of declared interests included in the pack of papers, and to declare any interests arising from the agenda or papers presented for the meeting today. So could I check whether there is any additional declared interests that any of our board members would like to make at the beginning of the meeting? None. So on that basis, I'd ask the board to note the register of interests. Moving on to item 3, minutes, action log and matters arising. Included in the pack of papers is the minutes of the previous meeting that were held on the 18th of January 2023. Could I ask whether there are any comments on the accuracy of the minutes of that meeting? None? Okay, thank you. So on that basis, we approve those minutes. The action log has been updated to reflect the latest position on open actions, in particular relating to the long-term strategy for urgent and emergency care, where we will bring an update to the board in May. So on that basis, is any questions on the action log? No questions. So on that basis, the board will approve the minutes. Could I have a thumbs up to confirm approval, please? Thank you. Moving on to item 4, decisions made in other meetings, and I'd like to hand over to Sarah Blow, who will speak to this item.
Thank you, Chair. So this is an item that was taken in part 2, and the reason it was taken in private was because it was business or commercially sensitive. It was a decision that the board made to commence a mini procurement process through the increasing capacity framework. That's for elective care. So that decision has been made, and that is progressing.
Any questions from board members? No questions. So on that basis, could I have a thumbs up to confirm that the board is content to note the contents of the report? Thank you. Moving on to item 5, so we now have an update on cancer, and I'd like to welcome Dame Callie Palmer, who will speak to this item. Callie, over to you.
Thanks very much, Chair. And I think hopefully people know me, but I'm both Chief Executive of the Royal Marsden. I'm on the board as a specialist service representative, and I also have the pleasure of being the chair of RM Partners. And this is our Cancer Alliance, which straddles both South West London and North West London. I'm joined on this call by Susan Sinclair, who will be known to many of you. Susan is the Managing Director of RM Partners, and also by Dr. Emma Kipps, who's the Clinical Director of RM Partners. So the plan is, I think I've got about 20 minutes. So the plan is for me to just sort of talk to people basically about sort of national context for cancer and the role and function of RM Partners. Susan's then going to pick up on where we are now with progress in transforming survival and eradicating variation in cancer services in our ICB. And then I think Emma's going to talk about the focus for the next 2 years. So we have a sort of funding stream for the next 2 years to really continue that progress in improving survival, eradicating variation, and providing really high quality care to our local communities. So just if I talk about the role and function of RM Partners, many of you are very familiar with this, but just to talk a little bit about, actually next slide. Great, if you just pause on that for a minute. So RM Partners has been going for some time, but it's really sort of gathered steam during the pandemic in terms of bringing partners together to look at the whole pathway of care, to really tackle things that are effectively blocks for people coming forward and finding it easy to access services. And it's also responsible for a number of initiatives that should be truly sort of transformational in improving survival. But the whole point of RMP, it's one of 21 cancer alliances nationally. There's a whole community of Cancer Alliance leads and clinical directors for the alliances across the country that come together regularly to share best practice and to check in on how things are going in improving survival and quality of care for people with cancer. So it's the national guidance when the ICBs were set up is that the Cancer Alliance will be the work stream, the cancer work stream for the ICB. So that's the sort of overall role and purpose. All the cancer alliances nationally work across more than one ICS, and the purpose of that is really to be more effective and efficient and to get scale in achieving improvement in cancer. So across the country, they'll work with between 2 or 6 ICBs as the cancer system driving that change. The funding comes through my national cancer programme, so my other role as National Cancer Director. There is targeted funding that comes directly to the Alliance for specific initiatives, which we'll cover in a moment. And then there's fair shares funding that comes regularly to support the cost of the Alliance and the management of new initiatives in cancer across South West London, North West London. So in terms of national ambition for cancer, you can see some of this on this slide. The headline ambition is to accelerate faster and particularly earlier diagnosis of cancer, because we know that's the biggest thing we can do to improve survival. And so the early diagnosis rates in this country have been stubbornly flat since records began, but we're beginning to see them shift in the right direction. And RMP has led the way in much of that, things like its targeted lung health check programme. But the national ambition is to get from just over half of people being diagnosed early, so at stage 1 or stage 2 of their cancer, to 75% by 2028. So there's a significant funding flow coming through from NHS at the centre and from government to support that level of cancer transformation. So there's a doubling of the allocation of the next 2 years, so 23, 24, 24, 25, to try and really accelerate some of the work we've been undertaking. Some of the major programs, I know Susan and Emma will talk about in a little bit more detail, but just some of the things that are shifting the dial nationally, and we're also engaged in locally, are things like targeted lung health checks. So lung cancer is very high volume, tends to be very late diagnosis and poor survival. Where we have introduced low-dose CT scanning closer to communities, so in football stadia, supermarket car parks, to encourage people to come forward, we've completely reversed the number of people who come forward early. So in the sites that we've had, we were diagnosing less than 20% of people early. It's now around 76%. So strategies to make it easier for people to access healthcare, really targeting particular communities, for example, with high levels of smoking or high levels of lung cancer mortality, is really making a difference to our ability to improve survival and access to services. So the other sort of major thing that's being rolled out is sort of national, but will be involved locally, are basically blood tests to try and pick up cancer early in an asymptomatic population. So in the general population, so this is being run in 8 cancer alliances, and RMP we're going to be picking up and helping to support the next stage of that development. And that would be a huge advance for early diagnosis across the country. So the alliances play this vital role, and RMP has actually been a leader across the country, thanks to Susan, Emma, the clinical directors and the teams contributing to it. And the whole idea behind it is that we approach this as a whole pathway of care. We also want to try and prevent, but where we can't prevent, we diagnose early, we treat with precision, and we give patients a really good patient experience and good follow-up care. If I just sort of move on to, can you stay on this slide for a minute, and before I hand to Susan on a bit more detail on RMP and progress in RMP. So just the current position on cancer nationally is that 1 in 4 urgent GP referrals are now for suspected cancer, so that's a massive increase. So we're seeing huge volume, so record demand for cancer services. We're also seeing record treatment levels. So demand is around 120% of pre-pandemic levels, treatment around 105% of pre-pandemic levels. We've also begun to see this shift upwards in the early diagnosis rate. So you'll see in RMP, we're above the national average of 58% of people being diagnosed early, but we need to do better than that. We need to continue to improve. But nationally, thanks to things like the lung health checks, we're beginning to see that really improving, which I think is really important. Social deprivation is a major determinant of outcome if you have cancer. So it is very important that we have a big attention on eradicating variation. I know Susan will cover that as well in a moment. In terms of how we're doing on, so you'll probably have seen that there's quite a lot of coverage in the media of the cancer standards and the fact that we're not meeting them at the moment. Last week, what's happened is that we're really targeting the backlog of patients who didn't come forward during the pandemic but are now coming forward in large numbers. So we're trying to tackle the cancer backlog, and that's having an impact on the speed with which we're able to complete people's diagnostic journey. Most of the people on that cancer pathway are still waiting for a diagnostic decision, so they will not have cancer. But clearly there's more to do to try and speed up and make sure we get that backlog right down to pre-pandemic levels, and we're able to meet the conventional cancer standards. We're trying to move from 9 standards, which are confusing for the public, to 3 with government support, so that patients know how fast they'll be diagnosed, speed from a decision to treat to first treatment, and then the overall 62-day pathway, so that there's a clear set of standards that every member of the public has a right to expect. So in terms of the RMP, we've agreed a strategy, as you can see, with both boards in North West London and South West London. So we're working through this, and I think Susan's now going to take you through some slides on where we are now, the progress we're making as a group of partners in South West London. And then I think Emma's going to focus on the plans ahead for 23-24 and 24-25. So Susan, I'm just going to hand to you next, if I may, and then obviously we'll pause at the end and really happy to take questions. But over to Susan, please.
Thanks, Kelly. So to deliver the ambitions of early diagnosis that Kelly set out and reduce inequality, our strategy has defined 6 key programmes. Firstly, as Kelly's mentioned, screening people at higher risk of cancers is one of the best ways to ensure that cancers are caught early. And our approach here is to work with the national screening team to ensure everybody is supported to get breast, bowel and cervical cancer screening, and also to roll out new types of screening which will assist the early diagnosis of more cancers. And as Kelly's mentioned, the lung health check programme is a significant programme which really improves survival through stage of diagnosis. Coming on to our second strategic programme, Borough and primary care teams have a very significant role to play in ensuring a good awareness of cancer across the population, how to get helps with symptoms, and ensuring GPs are implementing all of the recent referral guidance. Focusing on this area will significantly improve early detection and reduction of inequalities, and we have cancer clinical leads in each of our boroughs working with joint priorities that have been agreed with John Byrne and Emma Kipps to ensure that they're able to support that. To ensure that to get actually diagnosed with cancer, normally about 2 to 3 diagnostic tests are required. And so another key focus and programme is to ensure that pathways are efficient and fast as possible in secondary care, and that access to different treatments is consistent across the patch. We work with clinical teams in hospitals to ensure this and change the pathway to make it improved, but also with the diagnostic and CDC programme in South West London to achieve this goal and make sure there's enough system diagnostic capacity. Personalised holistic care was a really important priority that our patient group were very clear needed to be a strategic requirement across the cancer pathway. Finally, we have 2 work programmes that cut across all others. Firstly, inequalities. We know that variation and inequality is a risk across all of the cancer pathway, and each of the programmes that I've mentioned have built in a review and action around inequalities to make sure that as we improve, we reduce inequality. And innovation, we know that even if we optimise every single part of the pathway, new innovations will be critical to achieving the early diagnosis ambition. So if we move on to the next slide, this data shows where we are now. And as Callie's mentioned, we have good early stage diagnosis in South West London with 7% above the national average. However, you can see from the table on the right that there is variation by borough, and reducing this variation is an important focus of our work with boroughs and primary care. Currently, we're working with each of the place teams to define local cancer priorities that are based around the core 20+5 inequalities framework. One of the most significant concerns following COVID was that people weren't coming forward, and we're pleased that since COVID, referrals have increased in South West London by 16%. Encouragingly, this is translating into more treatments. In this financial year, we've already done 400 more treatments than in previous years. Now, as Callie mentioned, this increase in referrals and treatments, if we move on to the next slide, means that in South West London, we're not quite hitting the faster diagnosis or consistently hitting the 62-day operational targets. However, South West London is holding up pretty well against this standard comparatively. Excuse me. And expects to be on track again by Q2 next year and stably maintain the target. Excuse me. If we move on to the next slide. So in terms of our general achievements, during COVID, our focus was very much on ensuring people that needed time-critical treatment were able to access this. And importantly, we created a cancer surgical hub very rapidly for both waves with our partners at the Royal Marsden to make sure people that needed cancer surgery could have that quickly and in a safe, COVID-free environment. We also rolled out fit testing, which is a way of assessing how likely people with tummy symptoms are to have bowel cancer. And this helps to prioritise the more invasive tests for those that need them fastest. And we have some of the top performance of this nationally in terms of our compliance with people being fit tested before their referral. We have key partners. We've got key partners with our providers both during and after COVID in terms of recovery, encouraging 2-week waits to come forward through primary care, supporting additional clinical capacity, supporting interventions to reduce the backlog to make sure that everyone has a decision and diagnosis within 62 days, and ensuring that cancer remains a significant system priority. And that's led to some of the improvements that we've already discussed. We also have continued with high impact transformation work during this time, including rolling out a vague symptom clinic for people who do not have an obvious location of cancer, but do have worrying symptoms. And we've made sure this is available across South West London with appointments at each trust to make sure it's easy for people to access. And that's got a 7% cancer diagnosis rate and 25% significant other diagnosis. So really helping to cut the time for people with more complex symptoms to get diagnosed. Callie's mentioned the lung health checks, and over 5,500 people have been health checked in Sutton, and we're currently rolled out in Merton and Wandsworth. We're also very pleased to be participating in some of the national trials that Callie with her national hat oversees, which are really about trying to find easier ways to diagnose cancer that mean that we don't have to do so many complex scans just to find out whether people do or don't have cancer. And we continue to work on these nationally to improve the early diagnosis framework. I'm going to hand over to Emma now to talk about our plans for the next couple of years.
Thanks very much, Susan, and morning, everyone. Next slide, please. So the next 4 slides give an overview of the work plan for this year. So in addition to the targeted lung programme, we'll be rolling out the screening and surveillance programmes for those at a higher risk of liver and esophageal cancer, which will identify more early stage cancers in our population before they have symptoms. We'll also ensure that patients diagnosed with colorectal, endometrial cancers have a genetic test that will enable eligible family members to undergo regular screening. And by using population health dashboards, we'll understand more about the variation in uptake in the national screening programmes for breast, cervical and bowel, and real-time data will allow targeted interventions as well as rapid evaluation. Next slide, please. So we know that there is variation in the stage of diagnosis and cancer outcomes by borough, and we'll continue to build on the excellent work by place teams to work with populations to improve the recognition of cancer symptoms. Our work with primary care this year will focus on 3 key areas: to increase the proportion of cancers diagnosed through a 2-week wait pathway and not through A&E, for example, to ensure that the use of FIT accompanying a 2-week lower GI referral reaches 80%, and to embed the urgent cancer referral guidance. Next slide, please. So we will ensure that all patients with a sign or a symptom of cancer have a clear diagnostic pathway into secondary care by continuing to increase the volume of patients referred through the vague symptom clinics that Susan just talked about. Once patients are referred and in line with national requirements, we're aiming for 75% of patients to be told within 28 days of a referral whether they have cancer or not. And to support this, we're going to be focusing on 3 pathways. Now, we know that breast pain alone is not a sign of breast cancer. So we will create a new service for people who have breast pain only, based in the community with expert assessment teams. And this will not only improve the patient experience for those group of women who are coming through the pathway, but it'll increase the capacity of staff and specialist diagnostics for those with a symptom of cancer. We're also going to optimise the urology workforce to make sure that people get diagnosed with prostate cancer quicker, and we will improve the speed of access to specialist diagnostics, which are needed by a clinician to make a treatment plan for patients diagnosed with lung cancer. For all cancer patients, we'll continue to support South West London to treat patients within 62 days, as Susan's discussed, and ensure that patients get the most appropriate treatment using our clinical pathway groups, chemotherapy and radiotherapy networks to standardise care. Next slide, please. So we will ensure that all patients in West London are offered the care and support that they need through the holistic needs assessments, and ensure all patients who have completed curative cancer treatment for breast, colorectal and prostate and endometrial cancer are supported through patient-initiated follow-up pathways. Critical to our work plan is to develop a patient and public involvement programme, and this involves patient and public in the co-design of whole system approach to rehab and prehab, and this draws on best practice and establishes a sustainable funding model. That concludes a brief overview of the work programme for this year. Now I'll hand back to Callie.
Thanks very much. I think we've downloaded quite a lot of information, and my personal thanks to Susan and Emma, who are really lead RM partners brilliantly and have done throughout the pandemic and beyond. So there's a lot of exciting work going on, which we hope will make a real difference in eradicating variation and improving speed and ease of access to cancer services. So a lot of work underway, a strategy agreed, funding line agreed, but more to do just to make sure patients get the best possible experience and the best possible outcome. So I'm going to pause there. I'm really happy to take any questions anyone has.
Thank you very much, Kelly, Susan and Emma, for that really good overview of the work that you are doing. Could I have hands up then, please, for any questions? And I'll take questions in sets of 3, if that's okay, and then come back, Kelly, to you to answer the questions. So Dagmar, Jonathan, and then Nicola.
Hi, so Kelly and team, thank you so much. I think it's really impressive, very, very welcome in all your work around cancer. I wanted, as an integrated care system, to really offer up what local authorities can do, and it will.
Oh, Dagmar seems to have.
Dagmar's frozen, I think.
Okay, whilst we try and get Dagmar back, Jonathan, could I ask you to perhaps continue, and then I'll come back to Dagmar.
Yes, of course. Thanks, Chair. And I just wanted, mine wasn't really a question, but just to say, as the Cancer Lead for the ICB, just to say thank you to RMP for the immense amount of work they've done throughout the pandemic, focusing on recovery, and now focusing again on transformation, and particularly a focus on the Core 20 group and addressing inequalities. The breadth of what RMP have managed to do, working closely with the trusts and the ICB, I think we really should acknowledge as a board. So it's really just to say thank you very much for all that work, and we look forward working very closely, as you've indicated, Callie, the further significant investment in cancer to improve more timely and earlier diagnosis for patients to save lives is such an important priority for us going forward, and we look forward to working closely with RMP over the coming years to do even greater things. So thank you very much.
Thank you, Jonathan. And Dagmar, I think you're back with us now.
Yes,
so
sorry, I got interrupted. So Jonathan has said it even more eloquently. So big thanks. What can local authorities do to support? So Cancer Alliance and the NHS cancer screening sometimes get all muddled up, but they are obviously different, but working in partnership, particularly around screening. And screening is an area where local authorities really can help. We had our overview and scrutiny yesterday, and there was really enthusiasm. We had worked with the teams before, and now the councillors were up there and saying, we are out there, we've got our surgeries, tell us, and we will promote, because it is very close to people's heart, cancer care. So count us in. That's one. And the only other one was around voluntary sector. We are close to the voluntary sector, and there's now so many survivors of cancer that actually still could do with a bit of help. And again, how can we work jointly as a system?
Thanks, Dagmar. Nicola.
Hello, thank you.
So
you talked about early cancer diagnosis being a priority, absolutely. So I just wanted to take the opportunity to, well, two things really. One, to emphasise how important it is that we ensure that our general practice in South West London is supported to be effective because of its very significant role in delivering this. And I can see that you are very focused on that, so I really welcome it. It's so important both in screening, but also in implementation of the pathways leading to those diagnostics and the early referrals, because the numbers we screen and refer are very large, remembering that most people don't turn out to have cancer. So, you know, the numbers are really big. So the general kind of health and well-being of general practice itself is absolutely critical to enabling the management of that work and the pathways. And I think you've got a really good focus on that, and a track record, it has to be said, of really excellent primary care leadership within RMP, which clearly helps. And as you said, we've got cancer clinical leads in each place, and I think that's a very effective model in my view. I just wanted to flag, though, an additional possibility, and one of our agenda items later in this meeting is on about the delegated arrangements for dental, optoms and pharmacy. And I wondered whether you're considering how those professionals in those services in our communities can sort of support this in prevention, but also perhaps in early detection. I didn't know if you'd got any work streams thinking about that.
Thank you, Nicola. So, Callie, I'll come back to you to answer those questions and then I'll take the next steps.
Thanks very much. So let me start, and Emma or Susan might want to jump in. So thank you very much, first of all, for all your very constructive comments and support, which is very appreciated. So just in terms of Dagmar's point, I think it's sort of there are a range of points here about local authority role, communication with the public, how we can enhance our screening programs, and then how we support the increasing number of people who will be living with cancer. So it's the sort of survivorship agenda. So I mean, we're thinking, when we started RMP, the focus was very much on the acute part of the pathway. And I think increasingly we're trying to make sure that we're working across the entire pathway, really focusing on working with primary care and thinking about communication to different communities to encourage people to come forward. So any ideas you have, Dagmar? Susan and Emma might want to talk about some, but I think all your points are very important, and the more we can help communicate effectively to the public, the better. You know, nationally, we've been trying things like a fear campaign to get people to come forward just to get checked. Nationally, we're working with a primary care group on decision support tools for GPs, on supporting with fit rollout through the GP contract and through sort of comms and working with Cancer Alliances nationally. But anything else, Dagmar, you think we should be or could be doing, then please do let us know, because this is all about, you know, the complete pathway, trying to prevent, and then where we can't prevent, you know, swift early diagnosis and really high quality treatment. Just in terms of how people access the service, so Nicola's points about community pharmacy and also supporting GPs. We've got a range of trials going on we've done a lot of training of community pharmacy, and we're trialing both self-referral. Not sure that's going to be workable, but we are trialing a bit more focus with primary care advice and support, how people access services or access the pathway through community pharmacies. So that we've done the training, we've got a model in place, but we need to evaluate it just to make sure all the governance arrangements and the patient experience arrangements are going to work well. But it is working. It's working with our primary care community to say, how can we both support GPs with decision support, with you know, rolling out these sort of more targeted interventions on screening, like the fit testing, for example, in primary care, and then how can we work to ensure people can access services without putting undue fees. So your comments are very well made, and if there are any specifics that you wish us to take up offline, then really happy to do that. But that's all right, it's a bit of a ramble, but Susan or Emma might have a slightly more specific response. But they're really good points, really important points, and there's more to do, I think, is my sort of summary.
Thank you, Callie. I'll just add with a couple of specifics on there. So I think we absolutely welcome working across the integrated care piece, because we know 50,000 people in South West London are living with and beyond cancer. One of the things that we are doing in partnership with the population health team in South West London is actually producing, and we're expecting this to be live by May, real-time screening metrics for starting with cervical and bowel that tell us not just in real time how the percentage by GP practice, but also at-risk populations that are not taking up screening. So we know, for instance, having done this in North West London, that the under 30s are very unlikely to have cervical screening. And we also know across South West and North West London that there's a 17% variance by deprivation in those that have or do not have bowel screening. So the least deprived areas are 17% more likely. So this will give us actionable insights that we can also measure the impact of intervention on. In terms of the detection rate, which is one of the points I think, Nicola, you were making about how do we work with practices, not just on screening, but actually on their detection and management. We know that from the NCPED survey, there's a differential in some groups of patients coming forward, and I think that's really about working with our place communication teams that I think are consistently delivering very deep integration and engagement with at-risk groups to understand what we can do better about cancer awareness and why they may not come forward. And then in primary care, we're using something called detection rate, which looks at practice level use of 2-week weights to diagnose cancer, to understand and influence 2-week weight utilisation as a means to diagnose cancer. And that's probably our biggest primary care programme next to you, Nicola. Emma, did you want to add in anything?
Only to endorse that both of those programmes, critical to them is the integration of primary care in the programme, Nicola, to support what you said. So we now have, also, as well as primary care leads at borough and place to implement this work stream, there's also representation from primary and secondary care in all of our pathway groups and clinical groups.
Thank you. So I'll come to Gloria and then Karen, please.
Thank you, Ruth. And I just want to say thank you to Callie and the team. Thanks for all the great work you're doing in cancer, and more importantly, really embracing that health inequalities aspect of it. Really good. And I know your team are very engaged because they've been working with our team to really make sure that we are looking at how we can support you better. And also really want to thank you for embracing Core 20+5. I think, again, you are one of your team and one of the people that actually put this up. Nationally, I think we are really doing well in terms of that. I just want to ask a question. I want to ask 2 questions. The first one is when you say you have seen the increase in referral rates up to 16% for the urgent suspected referral cancer. So is that in your Core 20 group, or is that generally, and have you seen any increase at all in your Core 20 post-COVID? That's my first question. Then the second question is around your performance in terms of the treatments, or early cancer diagnosis. 58% is impressive. Again, above national average of 51%. I think that's really good. But I just want to ask, in terms of Core 20+5, our target is about 75% early diagnosis in the Core 20+5 by 2028. They are talking about stage 1 and stage 2 of cancer. I just want to find out, are you planning to achieve that, or are you planning to meet that target by 2028?
Thank you, Gloria. Karen.
So just to echo what Gloria and Jonathan really said about our thanks for all that you're doing and have done through the pandemic for patients, and all that you'll continue to do. I suppose my question was to try and have a deeper understanding of the variation that you pointed out, Susan, and you said, didn't you, that population health management and the work that we're collectively doing will help get a deeper understanding. But I just wondered whether you could say a little bit more about the reasons that you think we're seeing that variation across the boroughs, and as a system, if we were to take more accelerated action, the kind of change that we could see.
Thank you. And Callie, I'll back to you to field the questions.
Thank you very much. So I'll just say something about variation and performance by 2028. Then I'm warning Susan and Emma, I'm handing over to them on further details. So just on variation, the really interesting thing, Karen, is I've just seen some data. So this is national, so forgive me, it's not South West London, but it's we've been leading the way with Emma and Susan. So for the first time, because of things like lung health checks, so high volume, targeted intervention, for the first time, the most deprived populations are accessing services faster than the least deprived. We've not seen that before. Mm-hmm. So some of these interventions are creating a big switch very quickly. Now, obviously, we want everyone to get into service fast, but it's really accelerated the people who weren't coming forward just by making it much easier for people to come and get a scan in a location convenient to them. And obviously, we've been doing some of that work through RMP. So I'll get Susan to talk a bit more about variation across boroughs. Just headline on Gloria's question about the 75% standard. Yeah, we've always had a hockey stick, so we're sort of moving here, and obviously the high ambition to get to where we need to get to, notwithstanding the pandemic, by 2028. But if we continue to see the impact with things like lung, with fit testing in primary care. If the Gallery blood test comes off as well, I mean, that could make a massive difference to our ability. So that turns into a national pilot from April 24. You can just see these things beginning to have a really big impact on getting to that 75% by 2028. So the mission is to do that, Gloria. We've still got a way to go, but we always were sort of modelling a bit of a hockey stick approach, because you need to put a lot in to get that shifting. But just beginning to see that shift is really exciting. But let me hand to Susan on the more detail on the variation and your points on the increase in referrals in the core 20+5, Gloria.
Thanks. So I'll start with the question Karen asked, and then Emma will follow up with Gloria's answer. So I guess in terms of local variation, we've spent a lot of time analysing that by tumour site and looking at sort of pretty much every factor. And I think probably the best framework that we found is the WHO early diagnosis framework. And that's because there is not a single intervention that will equalise everything. It basically comes down to 3 focused areas. One is patient interval, so making sure that every group in our population both knows the symptoms and is able to access help for cancer. And that's really why targeted communication rather than general communication is now critical, because that gap is probably quite big in terms of understanding. The screening gaps and making sure that while we know that overall our national screening programmes have done a huge amount to stage shift diagnosis, where we have variation, we have inequality, and that continues to need to be focused on. And when we think about our targeted lung health check programme, one of the big things we're really focusing on locally is how do we make sure that's equal, because we know that smoking rates effectively directly correspond with deprivation rates. So it is a disease of deprivation, lung cancer, and that's the way we're treating it. And then finally is the piece around the referral interval, which is effectively ensuring that every patient gets referred with a similar set of symptoms in the same timeframes. And that is the piece of work that we're really focusing on this year, to understand some of the patient, system and population and even clinician factors that may affect that, and then start driving targeted interventions to equalise that. So no one quick win, I'm afraid, but lots of focused targets to get there.
May I just add something to Gloria's question, or your response to Gloria's question, Callie, which is that I'm very proud to be working within an ICS that has basically been responsible for driving the research behind what will end up being rolled out nationally to close that gap in early diagnosis. And 2 examples of this that are currently happening is that we know that we're using circulating tumour DNA for early diagnosis in head and neck cancer, and that's in Kingston, as well as circulating tumour DNA for those on a protracted diagnostic pathway with harder to diagnose cancers like biliary tract cancers, and that's being led out of our system, and we should be very proud of that.
Thank you. So are there any further questions from board members? I see no hands, so I'm just going to hand over to Sarah to give the final word.
Yeah, so I wanted to also thank RMP for your leadership, but I think we should not forget that RMP is made up of all of the partners in South West London, so all of our acute trusts, primary care, community places, and that I think is what has led us to what is a very successful outcome for local people around cancer in South West London. Obviously, there's always more to be done. I know that and I recognise that, but actually outcomes for our local people are much better than they are in some other areas. So I do think it's worth recognising not just the fantastic leadership we have in RMP, which we have, but also the leadership within all parts of our system that have enabled this to happen. So thank you all.
Thank you, and if I could add my thanks.
Thank you, Chair.
Okay, so is the board content to note the contents of the report and the discussion that we have had? If I could just have a thumbs up, please. Thank you very much. Moving on to item 6, South West London Enhanced Health in Care Homes Programme, and I'd like to welcome Tonya Nicolaides to speak to this item. Over to you, Tonya.
Thank you, Chair. And yes, I'm really pleased that we're able to bring this really important piece of work to the board today, because I think it shows some real green shoots of success, but obviously more to do. I'm actually going to hand over to my colleague Vicky Nelson, who is the Assistant Director of Ageing Well, who has really been leading this programme for a number of years now, and it was through her hard work and tenacious approach that we've got where we are in South West London. So over to you, Vicky. Are you happy to talk through the presentation? Can I just check?
Yes.
Is someone doing the presentation, or should I? Yeah, sorry. But we have got it in front of you. I don't know if you want to start, Vicky, and then I'll wait for we can have the presentation later.
Okay, thank you. Yes, I've got the slides in front of me here, so I'll just start working through those. I know that they've been sent to you in advance, so I'll just go briefly over them so we've got time for discussion or feedback. So yes, just to introduce myself, I'm Vicky Nelson. I'm Associate Director of Transformation at South West London ICB. I oversee the Ageing Well programme and the End of Life Care programme. Ageing Well is one of the 3 core areas under the long-term plan, and Ageing Well consists of community services transformation, proactive care, as well as the enhanced health and care homes workstream, which is what we're focusing on here today. So on the first slide within the pack, it sets out the enhanced health and care homes framework, which is a national framework that's been set around how the NHS is working with care homes and the local authorities as well. And it very much is the kind of underpinning guidance for us to be working towards as dictated by the long-term plan and the operating plan, which says that we need to be self-assessing against this framework and levelling up or improving our compliance with the framework. The next slide just gives you a brief overview around the situation in South West London, or the landscape. We've got just under 350 care homes in South West London and around 8,500 resident beds. The actual resident population does vary depending on the level of occupancy within the beds, and then around 10,500 staff. And of those care homes, around 97 are nursing homes, 59 being residential, and the remainder being homes for people predominantly with a learning disability, but also some homes for people with a mental health condition. The other thing that I think is interesting to bear in mind is that within those care homes, the NHS and the local authority commission a number of beds, but there is a very high percentage of independent self-funders within the South West London care home beds. So if we just go on to the next slide then, thank you. And I think this is an important thing just to highlight is our principles. What we've really tried to do is have a very supportive, working alongside or working with the care homes, trying to get away from a doing to approach. They are independent organisations, so we need to work alongside of them and with the kind of levels of sort of statutory placed beds. You know, a lot of care homes don't have any sort of statutory placement, so it's very much trying to use a encouragement and I suppose pulling along rather than push. I think too there's been a lot of issues in the press. What you generally tend to see is the negative stories about care homes. So there is a little bit of cautiousness when we're working with them. You know, you don't see the lovely stories that we see when you're actually going out and working with them. So really trying to build that that sort of trusted relationship of working together. So on the next slide, just a little bit about our governance. So we do have task and finish groups focusing on the projects that we're working on. We have strong clinical engagement. We have the transformation leads at place who work with the kind of South West London based team. It's a very much interactive working together arrangement. And also we've got the local authority involved in the strategic oversight along with the NHS. So on the next slide, just having a look at some of the projects that we've done, so some of the and the highlights, and of course behind all of these lines there is a deeper story that I could tell you, but just to try and give you that snapshot, our transformational projects have focused very much on kind of the NHS support, so through our care home support teams within community services and working collaboratively with the care homes. Also with primary care, we've got the enhanced health and care homes DES that had come out, particularly with focusing on aspects such as the MDTs and the effectiveness of MDTs. And also looking at the training and support, particularly around things like falls, things like challenging behaviour, and the leadership support for care home managers and clinical leaders in the home. And then around the pathways, such as the red bag pathway or hospital transfer pathway, and then the use of early sort of deterioration tools such as Restore and Use2, and the pathways around there that are available to support care home residents. So on the next slide, we've got the winter resilience. So on top of the kind of projects that we've had over the year, we've had a bit more focus in response to the NHS winter resilience guidance that came out, particularly focusing on the use of the UCR and alternative services available to the UEC, and again trying to mapping falls and trying to enhance the falls training and support, particularly for care homes with a higher level of use of UEC due to falls. On the next slide, so we also have, so at the moment we've had somewhat separated our clinical transformation and our digital projects, although in actuality there does need to, there is an intertwining that happens between those. And I'm really pleased to say that we do have a very extensive digital program of work with our care homes, and are one of the most progressive in London in terms of what we've been able to achieve. And one of the key areas is this support that we've been giving the care homes to achieve compliance with the Data Security and Protection Toolkit. And that's a really key IG gateway that they have to comply with in order to allow further digital integration. Pre-pandemic, we had only around 20% of the care homes who had achieved that compliance. It's actually quite a very complex and complicated piece of work to undertake unless you have people with specialist knowledge, which a lot of our smaller care homes don't have. So we have been able to support them to do that. And we're now really pleased. We're overachieving against our target, but that means around just over 85% of the care homes now are at that compliance level. So by being published at standards met on the DSPT, that enables them to access further integration. So things like the NHS mail, setting up remote monitoring within care homes, and also things like the e-red bag, which is the electronic transfer of information into care homes, into the NHS when they are admitted to hospital. The other pieces that I think are really important and worthy of note is that we have been able to get some of the care homes, a small number, so we just got 9 in the pilot, to have access to the London Shared Care Record. For me, this is like man walking on the moon. It's absolutely fantastic that the care homes are now able to have access to NHS information. So in real time, when a patient is discharged from the hospital, they can see that discharge summary straight away. That can really help support them looking at things like medications, changes in plans. So really, and we've had some absolutely fantastic anecdotal feedback from the care homes about how that has really helped them with their care of their residents. So just going on to the next slide, and this sets out, because I think if you ask people, residents in care homes or their families, they already think that all the information that the care home holds, the NHS can see, and that the information the NHS holds that the care home can see. But of course, that's not the case, and there's real benefits to both parties being able to see that information to help with their care. And this is sort of a little pictorial display of some of the steps that we're going along to try to achieve that ultimate goal of digital and data integration. So if we go on to the next slide, so that's a little bit of it, and this is just a little achievement highlight. As I said, one of the things we have focused on is the red bag pathway, which has been around for a while, but with COVID, we've had such a sort of turnover in staff, both in care homes and in the hospitals. So we have invested in red bag coordinators in each of the acute hospitals from the Ageing Well funding. So that's been really supportive at trying to track down some of the issues, like if bags have gone missing, and trying to re-embed this pathway back into practice. So that's a little bit about the projects, and the next slides are looking at the impact, because obviously we've done a lot of work, so what's actually happened. And I think just to bear in mind too, there are always caveats around data and kind of data quality and so on that we have to be mindful of. And also that the complexity of residents in care homes is increasing. They are getting older, they are getting frailer. We've got medical advances extending life. So there is a lot more complication, and what we could almost expect is that actually there would be an increase in growth or an increase in activity due to this dependency. And I think this data that we have here just tells one side of the story. Also, what I'd love to be able to do, what we need to keep doing, is really capturing and building that sort of subjective feedback from staff and carers and residents, and how these programs have impacted and helped them. But let's have a look at the data, and I've pulled these together, and I know it's sort of quite small, but hopefully you can enlarge on your screens, but I think together it builds its own picture. And this covers data from January 2019 through to November 22. So what we can see is, in terms of, we've got an increase in the top left-hand corner in GP activity, bearing in mind that we have had the introduction of the Enhanced Health and Care Homes DES. So there's almost an expectation, as there's sort of increased incentivisation and support for GPs, that there has been an increase in that activity. On the right-hand side at the top, we can see the A&E and activity, which overall has remained sort of largely steady or a slight decline there. But what's quite interesting on the bottom left-hand corner is the actual non-elective admissions, and we can see that we've had a decrease in those level of admissions. And then on the right-hand side is the length of stay. So while this has gone up, there is something around, so while we've got decreased admissions from the care homes, the lengths of stay have gone up. So is that sort of indicating that actually the people who are coming in are actually unwell and much more complicated and complex with their conditions and really needing that care. Well, I've also brought to you today some details around the LAS activity. So as part of the winter resilience, NHS England commissioned an external provider to assess the LAS data across London for care homes. So this is based on their reports. And what we can see is that while South West London has the highest number of beds in London, we actually have relatively few daily care home incidents compared to the other London ITSs. And when you look at that too, sort of 13 of the kind of 20 on average end up being conveyed, but 7 not conveyed. So what I'm hopeful of, and what we're looking at across the system, is that the other systems and supports that we've put in place and the pathways mean that the care is being picked up earlier and other support is being given. But there are actually, when they do call the ambulance, largely that is because people have become unwell, that they do need to be conveyed to hospital. And the next slide talk a little bit more about that, that we have the lowest incident rate per bed. So the one above sort of showed the kind of overall not weighted per bed, but even when we look at weighted per bed, we've got the lowest incident per bed rate. But actually when someone is called, that person is more likely to be unwell and actually need to have that support from the acute hospital. And the next slide sort of talks a little bit more, shows that a little bit more broken down by borough. So just going on to the next slide, as I said, we do have the data, but some of the other sort of softer intelligence and benefits, because with the digital program, what we don't have is these are new sort of roles we've had to bring people in. There's not a sort of specific training course or program or degree or diploma that people can do. So we've had to sort of bring people in, and a lot of these have been from sort of outside of the NHS, at people from different backgrounds who bring different skills, and then actually putting in our some time and training to invest in developing these staff. And those other skill sets they bring, so some sort of really varied backgrounds, have been really useful in them actually engaging and working with the care homes and being able to provide that supportive approach. And what we're seeing now is some of the other sort of ICBs across London are taking this concept of the roles that we've developed. So we've got DISLOs, or Digital Integration Support and Liaison Officers, and DISAs, or Digital Integration Support Advisor roles that we've developed, and they're starting to emulate them across other areas of London. And I think the other things that we can look at is this real strengthening of the relationship between healthcare system and care homes. And I know care homes, some of the feedback we've had is actually we start to feel like we're part of the system now. We don't feel like we're on the outside, which I think is really important. And this digital readiness is really important, both from the healthcare perspective, but we've also seen is things like communication is improving, not only between health, but also with sort of family members and so on who may live abroad. Having kind of an iPad or a digital device has improved a lot of those communication and some of those quality of life aspects. Improving the knowledge and skills for the care home workforce has been really positive. And as we said, the communication, both health-wise as well as the impact on the non-elective admissions. So if we just go on to the next slide. And I think while we've sort of made this progress, we can never sort of stand still. There's always further that we can be going and looking back and reviewing how can we continue to help and support. And I think what we are mindful of is that we do have care homes, some who are very engaged and very proactive, and there are others who are probably the kind of latter followers of some of these things. So how can we make sure that we continue to support those care homes so that we don't end up with residents or care homes being left behind? We know that the workforce in care homes is still transient. There's high levels of turnover. So this training, and often the training that we get is based on bid funding that we get, so not necessarily having that sort of long-term impact, although we do have care home support teams of some level in almost all of the boroughs now, but it's kind of sort of sustaining that on a longer term basis and being mindful that transformation does take time. And trying to have these roles that are supporting the changes within care homes and how we work together, and then what do we have as our longer term business as usual model. And I think the length of stay is also something that we need to keep looking at and reviewing. Are there ways that we can try to bring that down, even if it is people who genuinely have a need for more complex and complicated intervention? So that then takes you on to just our next steps and then some time for questions. So I think, as you can probably see, we have made a lot of progress, but still more to do, particularly thinking around the sort of staff and resident turnover and also the transient nature of the funding that we have to do the work. As we said, the workforce issues, even though they're independent organisations, they still need support, and we can sort of see some similarities with the way in which we've worked with primary care historically. And I think the really important too is that actually these are the most vulnerable people in society, and really there's a moral obligation as a society to be supporting these people, but also these people are the highest risk of putting pressure on the system, once they are admitted or if they are declining. And as I said, we have had a bit of separation between our clinical and digital, and what we need to do in-house is make sure that we bring these together into a single unified program. So I'll pause there. The next slide is for questions, comments or feedback. Thank you for listening.
Thank you, Vicky, for that presentation. If I could ask people to raise their hands that want to ask questions, and as before, I'll bring people in groups of 3. So I have so far got Jackie, Mercy, and then Nicola. So if I could take those 3 questions first, please.
Thank you, and please call me Jacqueline.
Sorry, Jacqueline.
So thank you very much, and thank you for your enthusiasm and passion for this, actually, because it shines through in what you say and how you say it. I suppose there's just some, so just with my improvement hat on, I was just looking at your transformation project targets. It's a conversation I have with in my own organisations about these are input measures, not output measures. So it's great that we've got, I'll just use red bags for an instance, 80% having a red bag, but what are the outcome measures that we know? So what you've put up at those 4 graphs are interesting, but it doesn't tie into me directly with some of what we've actually done. So whilst we can, because it just doesn't feel like this in the hospital, and that might be because of the length of stay. But when we look at our activity coming in, that doesn't seem to have dropped either. So I suppose it's about, if we take this cohort of patients in, let's say, at Wandsworth, for instance, how can we tie in what we've done with actually what happens, an outcome for that patient, whether it be admission or any other thing. And I'm just wondering whether we can do that a bit tighter, because otherwise it's a little bit too general for me. It doesn't directly tie into an outcome. And I think the second thing is having a patient story as part of this that illustrates something would actually be really good, because you talked about a lot of the qualitative bits of this about the experience of patients, which is equally as important, but we haven't brought that out. So thank you very much, Chair.
Thank you. Mercy.
Sorry, I'm just coming on camera if I can. Yeah, I was going to talk about red bags as well, but I think Jacqueline's point is kind of really good. Two bits that I wanted to talk about, and I guess I feel like I'm part of the patient story, because I've been doing this for 6 years, visiting my mother, so I wanted to know a little bit more about those kind of lower levels of admission, and you know, kind of the LAS data as well. And I wonder, is that because staff are more confident, they're better trained? And you know, I'm thinking about lessons to be learned, and I'm also kind of wondering how kind of families were involved in that. And certainly I work quite closely with kind of GPs and nursing care staff to figure out when it was appropriate to be sent to hospital or not. So I wanted to know about the impact and the information given to families really around those kind of discussions and things. So and the other thing around digital integration, it's really about support with the infrastructure as well, because many kind of reviews that I've done online, I've been able to get online. Local authority, now the NHS staff have been able to get online, but actually the care homes are really struggling. We've had to really wait for them to get online. So, so there's something really about, it's great that they're helped in all the kind of, you know, kind of the program and data security stuff. And, you know, the ambition is to give them the information. But when they can't even get online, it's, you know, kind of rather frustrating. So just comments on those two, please. Thanks, Vicky.
Thank you, Mercy. Nicola, and then I'll come back to Tonya and Vicky to answer questions.
Yeah, thank you. So, so Vicky, I really welcome this work on care homes, and it's very good that this board is hearing about it. I think it's really important, and thanks for your own personal endeavours on this, because I saw that firsthand during the pandemic, and I know how challenging it is. I know firsthand as a GP who has patients in a care home how challenging it is for care home workforce and the practices and the community teams involved. So this is a challenging kind of environment, and all these projects are really tough. So, you know, keep going. And just to focus on one area, and others, Mercy's already brought it up really, the urgent care plan is, it seems to me that this is a pressing issue, because avoidable admissions to hospital from care homes should be avoided. And the urgent care plan is really critical to achieving this and to improving care. And as you said, this has started. So GPs and the ambulance service and folks in A&E and in the end of life care services can all see the urgent care plan, but it can't be seen by the staff in the care home. And that's going to lead to the way that patients are managed in the care home will be affected by that, and things might happen which wouldn't otherwise. So I think that's got to absolutely be a priority. So you said it was man on the moon stuff, but we can't wait for space travel to kind of, you know, be designed for a few decades. You know, it's really got to be rolled out very quickly. So I'd plea for that. And then secondly, GP practices, so you showed that graph, and GPs spend a great deal of time looking after their patients in care homes, and in general the resource in the system to support that is lacking through national contractual arrangements. And you mentioned this increase in activity, but I think that might be simply coding the activity that's happening. GPs weren't required to do that before, and I don't believe there is a growth in the workforce in general practice that are delivering it. So I think we may be seeing an increase in coding of activity rather than a true increase in care episodes. And I think if we want to know we're making a difference, then we'll need to review how practices are supported to do this, building on the basics, perhaps through funding, but certainly through increasing capacity, skill levels of other community resources, and an MDT approach. I think all of that needs to be addressed. But yeah, thanks very much. I think you've made some really good progress in this. Thank you.
Thank you. So Tonya and Vicky, over to you.
I'll hand over to Vicky as she's the expert, and if you need anything, Vicky, let me know.
Thanks, Tonya. Yeah, please chip in if you think. Yeah. So just looking at Jacqueline, and yes. So I'm going to say you're absolutely right. I think I have so much information, but you're right. It would have been really good to have a patient story, wouldn't it? A resident story about what has happened. So I think that's a really good piece of feedback. And I think the other complicating thing, as you say, is the actual kind of parallels, isn't it? You know, what in on the left side produces what out on the right side. And I think that's a challenge that we've had. And even I had worked on the Vanguard, you know, that we had that same challenge then, is that actually it's almost like this basket of a basket of approaches that comes together and creating that output. I mean, we saw strong, through the Vanguard, we had seen strong correlation between the red bag, those with a proper red bag, and the length of stay. But you're right, it's probably we need to kind of look back and try and see how can we really kind of track and get that down to like to a care home level in terms of what's happening. So I think there's definitely a lot more to do. I think in terms of that kind of relation of what project is creating what impact, and making that more exact rather than kind of a global piece that we have. I don't know if you wanted to add on that one, Tonya, at all. No. And yes, again, in response to Mercy, the lower level of admission and information given to families. So again, sort of behind all of these projects, and there are projects that we haven't, you know, pieces I haven't necessarily expanded on, trying to keep it brief for the group. It's very much that kind of thinking around what is the information given to the residents and the families around them, and I think that's something that we've really had to build on. We have got some service user engagement, which is more challenging with care homes, so it's often looking at the family members as opposed to necessarily the residents who may not be able to actively contribute. So, but I think that's a good point for us to take away, Mercy, is to make sure we're picking that up within each of the pieces of work that we're doing, is how is that kind of translated back into the homes. So digital devices, and that has been one of our, and as I said, so I have sort of skimmed through, but that has been one of the pieces that we have focused on, ensuring that kind of, well, making the offer for all care homes to have some kind of device, the tablet, the device where they're able to undertake video conferencing. But and I'm mindful, as always, there may be people who have slipped, and I think it's perhaps we need to work with, again, some of our partners, system partners, to pick up, okay, what care homes are you struggling with, so we can approach some of them more directly, because we do have funding through the digitising social care records, so we can provide some support. And I know there are homes where we've helped with things like putting the Wi-Fi in place or having a tablet or device so they can participate in teleconferences. So that is kind of on our wider program, even though I didn't really talk a lot about it. But I think what's flagged to me is how do we pick up those that we've missed while we've made the offer, and it may be the rest of the system. And also that digitising social care records I hadn't sort of focused on, but what we found sort of pre-pandemic, we had something like 20% of the homes had digital records. So the vast majority had paper records. We've now worked with the support of the national kind of DISC funding, and we're just at around 51% of care homes being on an approved digital social care record. So I think that's also kind of going to be helpful as well in that sphere. And yes, Nicola, UCP. UCP is one of my targets for this year. We had the transfer from CMC to UCP, and I kind of left it, you know, thought let's not get too involved till that sort of settles, but absolutely. But having said that, they have to have be compliant with the DSPT. So all of this work we've been doing, having 85% means actually we've got 85% who could potentially, you know, be sort of switching on the UCP, you know, given the right steps. But it's not as easy as that. So right now, at this point in time, we are actually creating a user guide, which is the approach we've used, is having sort of a workbook approach, bringing this into simple everyday language. Because yes, UCP does have sort of guides for, you know, other people, but you know, the care homes have a different sort of language and experience and knowledge. So we're creating something, and we are working with UCP, but we're driving it from the South West London approach. And then we will be testing it with a small number of care homes to refine that model. And we absolutely have targets this year to increase the number of care homes who've got the UCP, because again, we have a very small number now, but we have some real champions who extol and say how much difference that makes, and really value having the UCP. So again, that's like our satellite into space, I think, Nicola, isn't it? And the work with primary care. So again, as you said, I think there's quite a lot to be done there. And in some ways it feels kind of more complicated and more complex. And I know we're all sort of got a lot of challenges across the system. And we have started around with a focus on MDTs, but as you said, I think it's that bigger piece. So that's definitely on our program to keep working on this year too.
Thank you. So I've got 4 hands up that remain. So I'm going to take those 4 questions and then hand back to Vicky and Tonya to answer those questions, and we'll finish up. So we've got Karen, Dagmar, Jonathan and Matthew.
Thank you. So we know the importance of care homes in our system, don't we? Particularly the importance that families and residents have for those. And Vicky, I think I probably just wanted to start by saying, mine isn't a question, by the way, mine's just a reflection, a reminder for the board, but to just acknowledge your very strong and enthusiastic, but your collaborative leadership that has taken us from where we were to where we are now. So thank you for that. I suppose what I just wanted to remind the board is through the Integrated Care Partnership, workforce is one of the things that is being discussed through the discussion document, and we've asked organisations to identify areas of workforce that we might want to work on together. I know through conversations with local authority colleagues that the care home workforce is one of those areas. So it may be that actually it'll be something that we work on together as we finalise the outcome from the discussion document for the ICP. So just the importance of that workforce, but also it may be something that we work across the ICP on together.
Thank you, Dagmar.
Hi, thanks. And Vicky, let me add my thanks, particularly during the pandemic. Absolute amazing leadership, and the care homes were obviously one of the areas of greatest concern, and really close collaboration with local authorities. So we forget it very quickly. It didn't come up on any bit on this slide. I thought, oh my God, you know, I still am a bit bruised from it. So wanted to put that in, and then my question builds on that. Obviously, public health put quite a lot of ICP support into care homes. I remember at the peak of the pandemic, you know, daily calls, etc. You will all be aware that this magic COMF funding, as it was called, contained management outbreak funding, is finishing at the end of March. Some of us have been quite creative to stretch it a bit longer so that we leave a legacy. And but for me, it's a really important quality of care angle in care homes. And obviously vaccination is going on. We've got flu, we've got norovirus. This is not going to go away. And we had some conversation with Gloria, I can't see her on the line now, but how, again, amongst all the asks and workforce stresses, how we cannot lose the ICP angle and the learning we had, and how we can keep up the expertise and collaboration with local authorities. But mine are leaving. That's just the sad reality. Thank you, Vicky.
Thank you. Jonathan.
Thanks, Chair, and thanks, Vicky. Just wanted to touch on the urgent care offer. I was really struck by the data you shared, Vicky, around London Ambulance Service and the relatively low level of conveyances, and suggest probably outside of here, it might be helpful to do some more work with our 111 provider as well. There are routes for care homes into the back of 111 services that might be able to further reduce the volume and numbers of patients who are conveyed unnecessary. And I think that we probably need to do some more work together to further enhance that aspect of the urgent care offer that we offer for patients. So it wasn't really a question, Chair, it's more an offer to join and connect our programmes even more closely together.
Thank you, Jonathan. Matthew.
Sorry, sticky mute button this morning. Just a quick one. I mean, I'd further endorse the positive comments made, Vicky, on work in this area. Vicky and I have also done plenty of work in care homes and vaccination, which is also a really important and positive piece of work. I've spoken to my team down here in Croydon, and they're also positive about the work that's going on, and we are sort of implementing all the schemes that we planned here in Croydon under this banner. One to perhaps pull out that has been not so much talked about so far is the partnership working with the voluntary sector, which has proved really successful at this end. There's some specific work that people have been doing about falls, nutrition, hydration, reducing social isolation, and care coordination, which for us here in Croydon is linking care homes residents with our integrated community networks, which is our mechanism to try to do neighbourhood working for groups of our population. So I think my point is this is sort of forming a part of that overall effort rather than it being seen as a separate isolated piece. It's very much part of a whole, and that voluntary sector piece I think worth just remarking on for the board.
Thank you, Matthew. Mark has also raised his hand since then, so I'm going to ask Mark to come in as well and then come back to Vicky, you to answer those questions.
So mine will be really quick. I think I agree with everyone about the passion and the presentation. I suppose for me the length of stay jumped out, and just are we tying that into all what we are doing around discharge planning, because we talk a lot about flow in the hospitals, and actually this seems to be a key area that we really need to focus on. So it's just again with Jonathan's vein joining up the different parts of the system to make sure that they're addressing the issue.
Thank you, Mark. Vicky, back to you for any further reflections.
Thanks, Ruth. Thank you. And thank you, thank you, Karen, and everyone. Thank you for the kind and positive words that you've given about me and Dagmar. Yes, it was for all of us, it was a very challenging couple of years through the pandemic. Yeah, but certainly the workforce, Karen, I think that's really positive that we keep connecting up, and I think there is a real focus on both the NHS staff but also social care staff that we're starting, we are developing, and I know we've done work with South London Partnership, and it's really positive. We've sort of invested some funding to support them with the development of the strategy last year for social care, and really exciting to see the Social Care Academy that they've been successful in. I think that will be really positive for our care homes as well as the wider social care workforce. Yes, Dagmar, I agree. That IPC support was just absolutely pivotal over the pandemic, but I think also beyond that as well, and it's sort of really picked up on probably where there's been a lot of gaps and issues. I know Debbie just mentioned that at the moment the sort of norovirus, Debbie Carroll, the IPC lead for South West London, she mentioned yesterday that the norovirus is kind of at the most highest prevalence that it's been across the country. Fortunately in South West London, no cases at this point, but it does make you think there's not only sort of COVID, there's lots of other aspects around IPC, and how kind of reliable, how up to date is the information and the training that care homes are getting, because it's not sort of a mandated core curriculum or anything like that, isn't it? It's kind of much more general. So I think it's been really valuable having that additional IPC support, and obviously this is things that we'll need to focus on and try to pick up, particularly going into winter again. What we have kept on, what we did during COVID was we had a weekly webinar followed on a Tuesday with our IPC lead who would attend and give the updates and be able to answer questions. And then on the Friday, a newsletter went out to the care homes, and invariably there were times where what was said on Tuesday had changed by the time we got to Friday. But it did set up a really good communication channel with our care homes. As we've sort of come further out of the pandemic, we've just recently dropped that down to fortnightly. So having the webinar as well as the newsletter. So we are keeping that as a conduit so that all care homes are invited to that, so and Debbie comes each time or a representative on her behalf to kind of give any highlights around IPC aspects, but also to be able to answer questions. And also the newsletter then has those updates. We also talk around other aspects that are supportive for care homes and information and so on, but we are keeping that alive through there, so at least trying to keep that thread in that way. But I do agree. And also the vaccination. So we did have previously the vaccinations. We had a project manager for care home vaccinations who was within our team, and that really helped us to drive forward and support the program, over the challenges that we had in terms of the vaccine program. But I will say vaccines remain, I think, an issue. While we had the mandatory levels during the pandemic, there was a very high uptake. That has, of course, dropped off somewhat now. And what we have always had, although we did increase a little bit, is also things around the flu vaccinations for staff. And this is around staff, rather than residents. So I think there's still a lot of work to be done in terms of empowering and informing and advising, and also just making it easily accessible for staff to be vaccinated against the flu as well as COVID. I think some of those things where we had staff going in and vaccinating both residents and staff at the same time was absolutely fundamental in increasing the numbers we had. And so I think that work is nowhere near finished. And even though the project manager no longer sits with us, we do need to find a way to try and make sure we influence and keep that vaccination aspect alive. Thanks, Jonathan, too, around the 111. I think, yes, absolutely. That's definitely a way an area to sort of further extend the program. And we do have a little bit of a slight complication there, in that there's sort of 111 and then there is 111*6, which is accessible to care homes, but that's hosted by the ambulance service, and 111 is by 111. So I think a few things and some of those issues that happen around there, but I think that's absolutely an opportunity for us to kind of expand and develop the program. And yes, Matthew, thank you for highlighting, Croydon's got a really great piece of working with the voluntary sector in terms of supporting the care homes. And I know we have the transformation leads who we're meeting actually at lunchtime today. We meet regularly, and in terms of the planning for next year, we're asking Croydon to share that approach, because that could be something other place leads are looking at could look at building into their programs. And yes, Mark, the length of stay, I'm hoping that we get more focus back on our kind of red bag or hospital transfer pathway. And I think there's a lot of opportunities to actually impact on length of stay, even without before I start scratching the surface. So the use of things like the red bag and the e-red bag, but also use of the UCP. And again, this is sort of some of those cultural changes for staff in acute hospitals as well, kind of being able to use all of those information resources to sometimes help with that flow, or even turn people around at the front door. So, and I'm sure there's a lot more that we can be doing even beyond those things. So it'd be great to think about how we can, I suppose, sort of help and influence that element of changing sort of ways of working within the acute hospital too.
Great, thank you, Vicky. Final word to Sarah.
Yeah, so thank you, Vicky, particularly for your personal energy around this. I know that you worked really hard, particularly through COVID and now coming out of COVID, and I think your personal energy has brought a lot to this in South West London. I think that's borne out by the fact that I know you were asked to come to speak to London about the work that's going on in South West London, because we are so far ahead actually in this in comparison to other areas, particularly on the digital side, which I know there is further to go, and I know there is more we can be doing, but I do think it's worth kind of reflecting that actually we are getting to a much better place. So, and I think the data sort of does prove that in some cases. I recognise what Jacqueline is saying, but I do think there is some good data there that shows that it's actually going the right direction. So I think we all want to support you. I think everyone recognises this is a system responsibility, so we all need to be involved in that, and we all need to take responsibility for that. So thank you very much for your hard work, and I think we'll have to think about how do we ensure that we continue to take this forward both through the ICB and the ICP as we move on. So thank you.
Thank you, Sarah. Is the board content to note the contents of the report and and the support to continuing development and delivery of the Enhanced Health and Care Homes programme. Thumbs up, please. Perfect. Thank you very much. So we're going to take a 7-minute break. So if I could ask everybody to come back promptly for 11:35, where we will restart the meeting. Thank you very much. welcome back everybody. I'm just going to give everybody 30 seconds or so to get back into their seats and on camera. Right, so welcome back everybody. So we're moving on to item 7 on our agenda, which is the joint working model with NHSE for specialised services to 2023-24 and ICB signature of the joint working agreement. And I'm passing over to Jonathan, who will speak to this item.
Thank you very much, Ruth. So the roadmap for integrated specialised services was published May of last year, and it set a expectation that integrated care boards would take on greater commissioning responsibility for specialised services where they were suitable and ready for delegation. And you may remember as a board, I came to talk with us back in the autumn about the full delegation of those services for 23-24 and shared with you the system readiness assessment we made at that point in time. Later in 2022, so the back end of last year, NHS England indicated that they wanted ICBs across the country to step together around specialised services, and they felt, given that ICBs were new organisations establishing themselves in their own right, that some ICBs across the country had limited capacity to develop some of the commissioning responsibilities, and indeed the pressures that they knew the NHS would face over this period, that they wished, rather than everyone stepping towards full delegation, that we would step together across the country through joint working arrangements in the 23-24 financial year, with the intention that again for 24-25, so a year further on, we'd all step together as all ICBs across the country to fully delegated commissioning for appropriate services. So this paper before you today sets out the joint working arrangements for establishing the joint committee function across London. So this is an arrangement between the 5 ICBs across the capital and NHS England for that transition year prior to full delegation. It covers the services that are deemed at this point ready and suitable for delegation, which are 59 service areas, so the majority of the overall spend. That group will also have a role in strategic decision making, leadership and oversight of the joint arrangements. All accountability ultimately, be it contractual, quality related or financial, will remain with NHS England through this transition year, and NHS England will therefore have the casting vote, and it will allow us to progress key work streams even towards the joint committee arrangements, including further work on financial planning and risk management associated with that, quality surveillance, transformation and the operating model. So that's what this paper seeks to do. It seeks to delegate that responsibility to Sarah as Chief Executive to sign that joint working agreement that we'll be signing in common with other ICBs across the country. There are a few local features that I've highlighted in the paper determined by NHS England London that relate to specific London governance and specific London leadership and clinical leadership arrangements also set out in the paper. I think the exciting bit to say is that South London remains at the forefront of the work nationally in this area. We are progressing as a national pathfinder programme and have some resource shared with ourselves and South East London to continue to progress the work. So we're very much seen at the forefront of this, and we're doing work with both colleagues in London and nationally to develop the right approach to financial management, business intelligence and contracting going forward. So that will that sort of joint working arrangements plus, as it were, will continue through 23-24 to get us in the best place possible to take on the additional responsibilities set out for 24-25. So hopefully that gives a good synopsis, Chair, of what I'm seeking some agreement to today from the board. Thank you.
Thank you, Jonathan. Any questions? Nicola.
Yeah, so it's not a question really, and I'm sort of almost embarrassed to say this really, because I recognise the reasons why this configuration has been proposed and the stage that we're at with the delegation. It's absolutely sensible, and others will know much more about that than I, but just wanted to flag really that this is setting off the work for us in South West London with and we want to be really good at this, don't we? We want to be leading edge. This is a very kind of, London facing stance, very kind of tertiary end of things. And I just want to make sure that when we then go into next phases, that we set up our systems to look at the whole pathway and not just the complex end of the patient's care, because these decisions are a long way from the patient. And I just think that's kind of just important to keep in mind, really.
Thank you, Nicola. Jonathan.
Yeah, I couldn't agree with you more, Nicola. And as you may remember when we talked about this in the autumn, the real reason that I think board members wanted to progress this is because we did want those end-to-end care pathways for patients. Some of the examples I highlighted at the time, for example, HIV testing happening in A&Es for all patients across South London, the work that we wanted to do on sickle cell pathways after some quite harrowing actual patient experiences described across the capital, particularly targeted at core 20+5 groups was another example I gave, and the renal pathway and the demand in that setting, and changing some of that so that we target and provide services early on for patients in the pathway is absolutely key. There are so many more examples, providing intravenous antibiotics outside hospital, cutting lengths of stay by tens of days for specialised patients and with certain cardiac conditions is another example. So there's a whole raft of work that we will want to do that's very much tied to end-to-end care and very much tied to the sort of core principles of the ICB about addressing health inequalities too. And thank you for highlighting it. It's an important reminder of that.
Thank you, Jonathan. So on the basis that there are no further questions from board members, please have thumbs up that if you're content to approve the joint working model for the commissioning of specialised services in 23-24 and authorise the ICB Chief Executive to sign the joint working agreements on behalf of South West London ICB to enable the new commissioning arrangements to go live from April 2023. Thumbs up. Excellent. Thank you very much. Moving on to item 8, pharmacy, optometry and dental delegation, and I'll come to Mark to speak to this item, please.
Thank you, Chair. So just to say, firstly, it's pharmacy, optometry and dentistry, now known as POD. It was DOP, but then it's POD again. So just to say that we've been working since last summer when it was indicated that NHS England wanted to delegate these down to local ICBs. That delegation will happen on the 1st of April. For London, that's around £892 million worth of commissioning functions, and for South West London, it's just under 130 million. It's important to note that it's delegating the commissioning functions. There are certain things such as contract negotiation, which will still be done at a national level. And in that 129 million, because it's a national contract, some of that funding is locked in to certain activities, but there is some transformation funding there as well, which will be of particular interest. As I mentioned, we've been working with our London ICBs, and we agreed an operating model with the other London ICBs because we wanted to achieve economies of scale. We didn't want to do this 5 times across the capital. We wanted to make sure that we were maintaining and nurturing that commissioning resource, and we wanted to ensure that there was consistency and a safe landing for POD services as of the 1st of April, and then we are on a journey of development, I think, from then on. It's fair to say as well that local understanding and expertise of the commissioning functions is developing, so we wanted to work with the commissioning function as is. So that operating model will be a host commissioner, and that's North East London. We went through a process to identify that, and they will basically house the commissioning function and the commissioning team of 26, and that transfer will happen from NHS. We will have a memorandum of understanding, a summary of which is provided in the papers, and which our Chief Executive will sign. And also we have established a London governance oversight group, which will basically steer the pod hub and the commissioning function going forward. But really clear to note, we are still the accountable ICB. 129 million will still sit on our accounts and our ledger. So therefore we are not replacing our own governance, we are establishing something that will then feed back into our own governance. On that note, I'll take the paper as read, but happy to take any questions.
Thank you, Mark. Any questions from board members? Matthew.
Not a question particularly related to the principle of the delegation, but just to note that there is, and Mark and I have corresponded a bit on this, there's increasing interest in this area from primary care colleagues, particularly in Croydon. I obviously just can't talk for other boroughs, but certainly from my patch, there's real interest on the basis that there is concern about the state of play with primary care, non-GP primary care, whether that be dental services and the ability for the population to access and for practitioners to wish to participate in NHS dentistry. Optometry, we have a very active optometrist locally, and Mark has been very good at sort of connecting up with colleagues, and so I think it's just worth the board noting that this could in some respects be seen as a bit procedural and not very significant and newsworthy, but I have a suspicion, Mark, that this might actually become quite a big stream of work with quite a lot in it, which could occupy quite a bit of our brain time and other focus, and that's probably not a bad thing on the basis it's quite a chunky bit of NHS provision. It's just one that doesn't always get the headlines, and I think that's one of the reasons why people are interested in making connections through me to you, and I'll continue to support them in doing that, but thought worth the board being aware that that's here. But obviously I don't disagree with what Mark is proposing going forward.
Thank you, Matthew. I'll bring Nicola, Dagmar and Annette in, and then come back to Mark.
Yeah, thanks, Mark, for the work you're doing on this. Many of us have got experience of the delegation of primary care contracting from NHSE to CCGs, as it was then. There are a lot of similarities with this, and it is really important to get the basics right. So I really support the approach that you're taking. The safe landing you describe of business as usual is absolutely critical. And from speaking to colleagues, particularly in optoms and pharmacy, I know that concerns them too. Lots of small organisations really at risk if their contractual payments don't flow and their contractual issues are not managed promptly. So that's a priority, and I can see you're managing that risk. But, you know, I think it shouldn't be underestimated. It's going to need a lot of attention. And like Matthew, I think that there are issues that will be surfaced. And I also think that our pod colleagues feel that there's a lot of opportunity and potential in these services to contribute to supporting general practice, to be involved in prevention. We talked about the cancer services and case finding, and to be part of the neighbourhood teams and to contribute more locally at place, providing the foundation is solid. So I think, you know, that should be the priority, but, you know, lots of potential as well.
Thank you, Nicola. Dagmar.
Yeah, I also wanted to build the challenges others have covered, and they're obviously pretty clear, but there are huge opportunities. So for me, community pharmacy as a resource in the community with wide reach with community languages as well, has again during the pandemic shown some of their potential with our pilot of social prescribing and community pharmacy funded through the South West London Innovation Fund. We're exploring more and connecting them in. So as we are talking the community model, that elusive, wonderful thing, and the primary care strategy, I think we need them in there, not only done to, but helping us to really shape and part and parcel of neighbourhood teams. So help and support for the opportunities.
Thank you, Dagmar. Annette.
Thank you. I just wanted to echo what Matthew was saying and what Nicola had said, and in fact what Dagmar had said as well, but just to add that I agree, there is a lot of interest in this, and there is a lot of opportunity here for closer working, not only with general practice and in the community, but as part of the integrated care system as we develop that for our colleagues in dental optometry and pharmacy. I just wanted to say to Mark that, as you know, there's been interest both at local levels. You helpfully forwarded on an email to me as well. I think it would be really helpful for us to get primary care leaders up to speed with what the arrangements will be, so that they understand what the commissioning arrangements are going to be going forwards, and the best ways for them to interact and engage with colleagues in dentistry, optometry and pharmacy. We have good relationships locally already in our patch with our local pharmacy committee. We know some of the challenges that they're facing. Colleagues in dentistry, optometry and pharmacy are reaching out to general practice leaders locally, and I think, you know, this could potentially be an area that could be, as someone's already said, quite time consuming but worthwhile. But I think some help with how best to engage and how best to do that locally in the most constructive way would be really helpful.
Thank you. Any brief comments, Mark?
So thank you for the comments. I think, yes, we have very interested parties across the board and across all of primary care, including GPs. But I do think that the feedback that I'm getting is that they are welcoming the delegation of the functions to us locally. I think it's really important that they are part and parcel of our integrated neighbourhood plans, and that's absolutely, we need to ensure that we are facilitating that. But remember that we do also have national contracts which are in some ways locked in. So we might be doing stuff in the transformation rather than the core contract initially anyway. And then on the next point, I think you're absolutely right. We are going to establish and are establishing optometry, pharmacy and dentistry steering groups. And that's for us to be able to galvanise it across South West London. And so therefore for the locals to really feed in to a South West London initiative and then can go back out and feed back to their localities. We're just looking at the membership to make sure that it's kind of representative of us all. And they are steering groups. They're not going to be decision-making groups, because I wanted to really try to ensure that the ICB current governance remained kind of paramount there.
Thank you, Mark. So recognising the challenges and opportunities, is the board content to note that South East London will be the host ICB for the Pod Hub? North East London, absolutely critical. well picked up, Sarah. Note that South West London ICB Chief Executive will sign the Memorandum of Understanding between South West London and North East London. Agree to the establishment of the London Pod Oversight Group with South West London representation as the key management group for Pod, and note the delegation of Pod commissioning functions from NHS to South West London as of the 1st of April 2023. If I could have thumbs up, please, that would be great. Thank you very much. Moving on then to item 9, which is delegation of the annual report and accounts committee update report. And Helen, I'm going to ask you to speak to this item.
Thank you. So the paper just updates you on the highlights from the last audit committee. Obviously, as part of that work and process, we've been focusing on the annual accounts and report for the year and the development of those and delivery of those. And as a consequence of that, at the moment, the ICB constitution in scheme of delegation asks for the board to approve the annual report and accounts, but we'd like to ask that to be delegated to the audit committee, who's going to do the detailed work, so that the formal approval could happen at that level, and then we would report back to the board.
Thank you, Helen. Any questions? So Martin first, and then Sarah.
Yeah, thanks, Ruth. I mean, I was just going to add my support to what Helen has said. I mean, I would be very happy for the audit committee to take on the approval of the annual report and accounts. So just wanted to add my support. Thanks. Thank
you, Martin. Sarah.
So this has been, I mean, I think it is a discussion point as to whether that is the right route. We had 6 CCGs at one point. 5 of them, it was in their constitution that it went to the audit committee, and 1 of them it went to the board, and we seem to have put that into our constitution. I think the issue is the detailed work does need to take some place somewhere else other than the board. I think what we can do is make sure that I think we need to rewrite the constitution to set this out when we do a change to the constitution, to say it should go to the audit committee for the detailed work, but we might want to put the final approval almost to the board once all that work is done. I don't know, but I think maybe we'll have a discussion outside. But I think for this year, what we can't do is the detailed work in the board, can we? So I think it's on that basis that we're asking for it to be delegated. But the board will still see the final outcome.
And we're delegating sign off of the annual report by the Audit and Risk Committee, to be clear.
Yeah. Okay. Well, I mean, I think that's fine at this point. I think as long as it comes back to the board.
It has to come and be presented to the board.
Okay. Okay, we might need to think about whether or not we want actual final sign off with the board and all the detailed work going with the audit committee.
Happy to do that. We just need to look at board meeting timetable in the line. We might need to do an additional board meeting just to do that.
Okay, that's fine. I think we might need to do that.
That's fine. Happy to do that.
Okay, so I think what we're agreeing to, we're asking everybody to agree to, is that the board notes contents of the report, agree that the delegation of the detailed work goes to the audit and risk committee, but that it will come back to the board for final sign off.
Yeah, and we'll probably set up an additional meeting to do that.
And in order to do that, we will set up an additional meeting.
Or we may need to take chair's action with a small group or something.
Okay, we will find the governance route to do it.
We will find it, but that's
the key bit is that the sign off is at the board, and that will probably need to be done between board meetings in some way. Okay, thank you. On that basis, our board members can tend to agree that. Can I have thumbs up? Excellent, so that is agreed. Thank you. Moving on to item 10, board assurance framework, and I'm going to ask Ben to speak to this item.
Thank you, Ruth. As the board will now be getting used to, the board assurance framework, the BAF, comes to the board twice a year, so normally in March and September. As part of our regular risk reporting cycle within the ICB, our risk register and the BAF are reviewed every 2 months by our team, so at team level with our executive directors, through the senior management team, and also through our audit committee. As we discussed the last time we reviewed the BAF is a living document. It is continuing to evolve and develop to reflect our current risk situation, and also as the ICB itself continues to mature and develop. As you'll see from the paper, we currently have 5 risks on the BAF, having closed or incorporated 2 of those into other risks. I wasn't planning to go through those in detail as you've got them in front of you, but very happy to take questions, and the BAF is here for the board to note. Thank you, Ruth.
Thank you, Ben. Are there any questions from board members? Okay, thank you. Is the board content to note the contents of this report on the board assurance framework? Quick thumbs up, please. Thank you. Moving on then to ICB reports. So at each ICB meeting, we receive formal reports from the quality, performance and finance functions. The first report is from the quality team, and Dr. Gloria Rowland, our Chief Nursing Officer, will talk us through the report. Gloria.
Thank you, and good afternoon all. So I'm just going to take that the report is being read, and I'm just going to concentrate on the executive summary, which is in the beginning of the report. And just to say, we've got about 3 areas that I want to really concentrate on. The first thing is to show some of the challenges we are still facing in the system in terms of staff turnover. The turnover is still a bit high, and I know there are a few work that is going on within the system to really help to change that. And I've said this before, I think in terms of retention of staff, especially around nursing, which is the highest profession in the system. Two of our trusts actually are in the two bottom end of having problems with retention of staff, and I know NHS England is working with us with that in terms of changing that position. The second challenging aspect that I want to report in this, that I want to reinforce, is around infection control. We've seen sort of like, I would say, a not consistent improvement in terms of how we do this. And it does range from one infection to the other. Initially, we have problem with Klebsiella, but now it's more or less E. coli. And some of the trusts, we are actually sort of like not really within our threshold. E. coli has been the one that we are really struggling with in the last quarter, and I just want to reinforce that. But I know we do have a system infection prevention control group, which is one of our strengths in Southwest London, and with that, we are looking at how we can make sure that we actually maintain the target rate. But sometimes it's just so difficult. You are solving one problem and then you have another one increasing. But it's not just about Southwest London alone, it's across the whole UK. They've seen increase generally, especially around E. coli, especially during the winter period. And finally, I also want to sort of like make mention issue around look after children. I think this is the one that we've reinforced throughout our quality report for some time. We've been reporting this for some time. And the reason for that is mainly there is a statutory requirement that we fulfill compliance with our initial review of looked after children. Is like the annual check, and we have to sort of like make sure that they are checked every year, and we are not compliant, and there's sort of like we have to then review the plan. We are not compliant. And the reason for that is there are a lot of reasons that is contributing to that, especially around pediatrics. Community pediatrics is a problem. They are actually providing some of these statutory function, but we don't have enough community pediatrician to help us fulfill this function. We are working as a system, and my team is working with James Blight, that is leading it in the system, to see how we can actually increase the number of people within this team. So what is really causing this problem is more or less lack of enough staffing, enough workforce. But again, across the whole country, when we benchmark ourselves, we will say we are on the average. Other areas are also struggling. In terms of workforce around pediatric is a national problem. It's not just in Southwest London, but we are working hard as a system to make sure that we look at how we get ourselves into a better position on this. But I just want to report that those are our key issues. One of the areas that people will be expecting me to report on is CHC. CHC is still a problem, but we are working on CHC. We are in a better position in terms of things that are happening across Kingston and Richmond. We have got our report from the independent review, serious review report, and there are recommendations there that we are working through that will be overseen by the Quality and Oversight Committee under Mercy's leadership. And also we have got the interim report for the future model of CHC care across Southwest London. Again, we are waiting for that final report, and we will share that appropriately through the Quality and Oversight Committee. I just want to mention that, and I'll pause there if anybody have further questions.
Thank you, Gloria. So question from Karen. Over to you, Karen.
Thank you, Gloria. I think I know the answer to this question, but I wanted to test it out. So the infection prevention and control is interesting to note, isn't it? So I wondered whether actually the infections that you can see increasing are cyclical. So is this a kind of a pattern that we would expect at this point in the year? I think I know the answer, but interesting to know that. And if the answer to that is no, I suppose my other surprise is, given the focus on infection control during COVID, whether there's been changes since then that have actually had a negative impact on infections in trusts. So two-part question, really.
Thank you, Karen. And the first question is yes. And we will see increases in some of these infections during this period, especially during the winter period. As we move into spring and summer, hopefully it gets better. However, the second question, I think you are right in a way, because COVID management is supposed to help us reduce the level of any sort of like nosocomial infection across the piece. However, there has been a lot of focus on managing COVID over the time, and I think one of the things we've said essentially is that we have to keep focus on other area of infection prevention, control, and these infectious diseases. But like I said, it does move from one to another. It's not like consistent. And don't forget, this is against the targets given to us by NHS England. And those targets are set by how we perform in the previous year. During COVID, the number of infections actually dropped. We didn't really see a lot of MRSA or anything as such. Again, with maybe washing of hands and good hand hygiene, that really helped a lot. So again, it's just about really keeping an eye on it. Like I said, E. coli at this stage or at this time of the year, in the second quarter of the year, is actually something that we will see an increment in.
Thank you.
Thank you, Gloria. Matthew.
Yeah, just to build on that point, I mean, we've been watching it and tracking it ourselves, of course, and certainly C. diff we've seen have a spike up, and I've been sort of asking questions locally about that. There are, as always with these things, factors outside of people's control, but there are also some factors inside people's control, and we're doing work on that to ensure that we are responding as we should, because historically we've had a very good position on IPC, but just a couple of spikes up over the last few months. The C. diff one is interesting because it definitely is something that is being seen more broadly across the country, and there is some sense that there might be different pathogens and stuff happening, which is something that the NHS is then going to need to respond to, because you've got to keep vigilant and keep responding as things change. And that, I think, is work that is underway, not just here but elsewhere too. So probably again worth the board being aware. Certainly something we're tracking and watching and doing work on in quite a bit of detail at our end.
Thank you, Matthew. That's a really helpful addition to that discussion. So if there are no further questions on that basis, is the board content to note the report? Thumbs up, please. Excellent. Moving on then to the next report, which is the performance report, and I'm going to ask Jonathan Bates, Chief Operating Officer, to talk us through this report.
Thank you very much, Ruth. So I'll take the report as read, but just to highlight a few key features. You won't be surprised to hear me start by drawing attention to urgent and emergency care. Performance did improve in January after a very difficult period in December across the whole range of key indicators, but we still know it's not where we would want it to be, and there are significant delays for patients in ambulances and in emergency departments at this point in time. Having said that, performance in January did improve significantly from that in December to 75% of patients being seen in 4 hours, close to the expected standard for 23-24. So we're already moving in the right direction there. I'd note the position on waiting list. Ever since the pandemic hit, we've seen our overall number of people waiting to access care grow in South West London. It was good to see that position plateauing in November and decreasing in December. So I'm hopeful that we might see some change of trend there. And on long waiters, we continue to be the best in London in terms of people who have waited more than a year for treatment. We have seen some growth in that. It's linked to the point that Dr. Gloria Rowland made about community paediatrics to some degree, and also the urgent emergency care pressures on the system. But I would also note the significant progress that George's have made really against that overall system trend and of a further reduction and reducing their long waitings by a quarter over the last couple of months. Other areas that have moved positively are some key cancer indicators. I won't call them out because we've obviously spent a long time this meeting on cancer indicators, but it's good to see them continuing to move in the right direction, as have health checks for seriously mentally ill patients. And then the areas of concern, as I say, I've already drawn attention to the challenges we face around 12-hour A&E breaches and ambulance handover delays. And the other one I would pick out here, because you see the changing trend, was around childhood immunisations, and the details in the paper. Some of that is data driven, but I don't think all of it is data driven. There's extensive work going on through the immunisations and vaccines teams around understanding the demographic cohorts that this is driving the position that we are in at the moment. There's further London-wide work also taking place, and we're working to address any of the confounding factors around workforce, etc., and competing priorities that people understandably have at this point of time, but also recognising the importance of delivering what we need to do for children on immunisations. So those are the sort of key headline points, Chair.
Thank you, Jonathan. Any questions or comments from board members? No comments or questions. So on that basis, is the board content to note the report? Thumbs up, please. Thank you. Finally then, coming to Helen Jameson, our Chief Finance Officer, who will talk us through the finance report.
Thank you, Chair. I will take the paper as read, and there's just 2 key points I would like to highlight to yourselves. The initial one is that the ICB's position remains on track for a £500,000 surplus, which is an improvement against plan. So as an organisation in our own right, we are delivering our plan. However, you are aware, board, that we have been holding a significant amount of risk over the year due to the inflation and the size of our savings programme, which was £280 million for the year. We have got to a position and through talking to NHS England and working with them and their protocol process, that we're not able to mitigate that risk entirely. And so we have moved to a deficit position at month 10 of 57.5 million by enacting the NHS England protocol. We are continuing to work with them on what that means and how we work and go forwards, obviously trying to ensure that we take ourselves back to a balanced position. We are currently in the process of developing a financial recovery plan to enable and support us on this journey as we go forwards, which is looking at all opportunities to do that whilst ensuring we ensure safe care and maximise access for our population. The second key thing I just wanted to note with you was that we received a letter at the beginning of March around the capital plan for the year. Since the papers went out, we have also received further guidance that requires us to publish the plan for 22-23 and also a plan for 23-24 and the risks that are within it and how we do that. And we would like to ask for the plan for 22-23 to be delegated, the approval of that to be delegated to the Finance Committee, just because we have to issue it on the 30th of March this year. So obviously there isn't enough time between now and then. That said, the plan will be the plan we have been reporting to this board all year, and against and is within these papers, so you have had sight of it and we know what it is.
Thank you. Any questions from board members? Karen.
Helen, I wonder whether it's just worth saying, because there's been quite a lot of work around the financial recovery plan, and it's a system-wide response, isn't it? I just wonder whether you wanted to explain to the board how we're bringing that plan together.
So we have been working through what is causing the imbalance between the allocation that we receive and the amount of funding it is costing us to deliver our services, to understand exactly what they say and what is driving that. And you will be able to see from our papers, and we've discussed this previously, our growth in workforce and our workforce costs are a significant part of that. But there are other areas as well, such as estates and contracts, that we have looked over and what we're doing. So we're creating a whole programme of work by looking and prioritising what the opportunities are to reduce that cost and that spend as we go forward across all areas of the system. So within the ICB, across how we're delivering clinical services, the back office functions that we have, our estates, etc., to understand all of that. And then we're developing a plan which prioritises those to say, where can we have these savings? Where do they come? How can we get them quickest? What would require more investment and is more complicated and do that. So we have a prioritised list and programme of work which we will then continue to deliver and push out over the coming months and years.
Thank you. Vanessa.
I hope this is the right and helpful place to bring this through, but I think we've got a real triangle, haven't we, around our financial challenge, our workforce challenge, and our quality and maintaining a BAU. And I think the work that we're doing through the sustainability and finance group is absolutely essential in helping us to triangulate those three areas. And it's just to make, just to raise, I think there's a real balance for us to get this right and to push through the financial changes that we need to make alongside maintaining quality and the support to our workforce.
Thank you, Vanessa. Matthew.
Yeah, just to build briefly on Vanessa's point. I mean, I think it is important to make the point that obviously the financial agenda is going forward looking exceptionally challenging. I think we're doing some good collective work on it, but we need to do that both mindful of the financial agenda as well as the wider responsibilities we have around quality, workforce, access, etc. They're all connected pieces, and part of our own individual responsibilities and collective responsibilities to make sure that we get that in the best place we possibly can, and that is going to be not easy, but I think the way that we started to do the work, we're keeping that in mind, and we need to do that as we go through what is undoubtedly going to be a pretty challenging period, I think, in that regard.
Thank you, Matthew. Joe.
Yeah, and I think I guess the only other bit in all of this, if that wasn't challenging enough, is also, and we've talked about this before, haven't we, making sure we're also focusing a bit on tomorrow and prevention and helping improve the well-being and health of the populations that we serve. So as Vanessa and Matthew said, it's a really sort of difficult triangle to keep in equilibrium, but that's our leadership challenge, isn't it?
Thank you. Helen, anything you want to say in response? Yeah. Okay, thank you. So noting those challenges and the collaborative work that will need to be taken forward in order to address them, is the board content to note report and also approve the delegation of the capital plan for 22-23 for sign off from the Finance and Planning Committee? Thumbs up. Excellent, thank you very much. Moving on then to item 12, Chief Executive Officer's report, and I'll hand over to Sarah to speak to this item.
Thank you very much, Chair. So this is a there's more information in this report, and I think that than we usually have. And I think the reason for that is that we've tried to have 2 in-depth items in this this month's board meeting, and I think that's been a really good discussion on both cancer and care homes. So there is a bit more detail in my Chief Exec's report. What I'm not going to do is read it through to you. I am going to assume you have read it, but I'd like to pull 2 points out. So the first one is around industrial action. You will recognise that today we are in the middle of an industrial action by the junior doctors. And as well as just updating you on the fact that we are working together and everybody is working very hard to make sure that we have as safer services as we possibly can in South West London, I just wanted to give my personal thanks in public to our chief executives that are managing this with their teams, and particularly those frontline teams, the clinical directors, those that are the nursing leads, the chief nurses, and also the operational leads on the ground, as well as all of those staff that have actually helped us to manage the gaps that we have in service in order to ensure that we can deliver those safe services. So and we do respect that our staff can strike, and you know, and we respect that right that they have, but it's our job to make sure that we deliver those safe services, and I think that everyone in South West London is doing a really good job of that. So I just wanted to give my personal thanks, and I will be writing to the chief execs to confirm that, but I wanted to make sure that we said that in public. So that was the first bit that I wanted to talk about. The second bit I actually thought I would just draw your attention to is the update on the South West London People and Communities Engagement Assurance Group. And I think this might be an area where we want to have a focused discussion in the future. So how we are engaging with our local population. This group actually oversees to make sure that we are doing what we should be doing, but there's an awful lot of work going on the ground, both at place, within providers and across the ICB. And I think this might be an area that in the future we want to bring a more formalised and in-depth discussion to a meeting. So I wasn't really going to say anything else about any of the other items, but I'm really happy to take questions on any of the items in my report.
Thank you, Sarah. Any questions from members of the board? Mercy.
Just a comment really, because I chair the People and Communities Engagement Assurance Group, and it would be really good if we do bring some of that kind of work to the board. We had a really good second meeting where we got a lot of information about what's happening at place, for instance, that I think can be showcased here.
Thank you, Mercy. Any further questions? Okay, on that basis then, is the board content to note the Chief Executive Officer's report? Thumbs up, please. Thank you. So moving on to item 13, these items are for information only and not for discussion. So we have the committee updates from the Finance and Planning Committee and the Quality and Oversight Committee. So I'm going to take them as read and for information only. Moving on then to item 14. So this is an opportunity for questions from the South West London voluntary community and the Social Enterprise and Health Watch England. So if I could come to Alicia Chase-Bilshes first, and then I'll come to Simon Breeze second.
Thanks so much. And just maybe for correction in the minutes, I don't represent Health Watch England, which is what it says on the agenda, but I represent the 6 Health Watch organizations within South West London. So I just wanted to just make a note about some of the comments that have already been made, especially in RM Partners presentation. I just wanted to echo some of Dagmar's comments. I really think that there's room for the greater integrated care partnership to contribute to the work that is being done in terms of earlier detection of cancer and helping to manage cancer patient symptoms. We, in our response to the integrated care strategy document consultation, we mentioned that we wanted to see a greater emphasis on cancer. And we think that something that Health Watch organizations can contribute to is in the signposting
of screening events to patients, particularly to those patients who are seen as being lagged behind. I know that a dashboard is going to be rolled out that will help us to identify those particular populations. And we can also help with some of the qualitative work to add context where we see, again, that patient groups are lagging behind and to identify why that might be occurring. I also heard that it was in the works for a patient engagement strategy to be prepared around the personalized holistic care planning work. And just to note that HealthWatch would be quite keen to be kept abreast of that planning and to feed into it if that's possible. Regarding the presentation on care homes, really pleased to hear it being noted that we do need some subjective experience to be collected from the patients and their carers. I think that just to note that while it's often more feasible to go to carers, those informal carers, right, the patient's families and friends, that oftentimes what their key interests are different. So it's been shown in research that carers are often mostly concerned about patient safety. The patients themselves might be more concerned, for example, about things like independence and overall well-being. So just it's very important to reach out to both of those groups where possible. And I just wanted to note again that HealthWatch can be a really strong partner in this type of work. We are already doing some enter and view work into care homes, and we can help collect those patient voices if we're requested to do so. If we're requested to share that information, rather, we are already doing this work. And then finally, I just wanted to say that I welcome Sarah Blow's and Mercy's comments about patient engagement being an area of focus in future meetings. And that's it from me. Thank you.
That's great. Thank you very much. And we will obviously note your responsibilities in the minutes correctly going forward. Simon.
Thanks, everyone. One update and just kind of one something on the back of that. So at the last meeting, I gave an update on the work around the South West London VCS Alliance. So there's two things on that. There have been sessions across South West London. I think all except for Croydon are complete. And that is to kind of share with voluntary sector organisations what's being done around the alliance, but also realistically to kind of clarify and update them on the work of the ICB, the way it's structured, because I think we've been doing that work, but until fairly recently, some of the structures have been a little bit unclear, and obviously those are now clear and therefore much easier to communicate. So we've been doing that, and then the other thing is as part of that work, a director post has been funded, and that's now been recruited to, and I think the post holder will start at the start of April. And then the final point is, and again, this was raised at quite a few of those cross South West London sessions. Obviously, we understand the need to review contracts and to find savings, but there are real issues with the process that's being put in place for voluntary organisations. So a lot of what was fed back in those sessions was the fact that, most organisations don't have directors of finance, or, they don't have dedicated staff members. Usually it's the lead officer who's dealing with things like contracting and tendering. And also, obviously, they often have very precarious finances. They're dealing with cost of living. We pay the same bills as everyone else. And I think a number of organisations across South West London have been put into a position where they've got 6 weeks left on a contract, some are out of contract, and they're being told there's a process. But then when they ask what's the process, when will it start, they're not being given clarity. And I think that's putting them in very, very difficult situations. I think probably risking some organisations' survival. So I would ask that that's kind of looked at, because if you're going to, for example, as is being done, bundle up a number of contracts and put them out for tender, that's something that needs to be planned in and kind of and supported. And you may get organisations who just aren't able to deal with that at short notice. So just to flag that really, because I think the kind of the incorporation of the voluntary sector into working and the value of it is great. Realistically, these are the sort of things where it's the words are great, but actions are going to be really important here. And I think this is where the message about the value of the sector will be sent, is how they're treated in these moments, rather than some of some of the nicer, shinier stuff. So I'll leave it there, but if that could be looked at, I think it'd be greatly appreciated.
Yeah, thank you, Simon and Alyssa. I'll ask Sarah to come back in response.
Right, so thank you for raising that with us, Simon. I think firstly, if you could maybe get in touch, and it's probably Jonathan, with where this is happening, because I don't think we're aware of it as South West London. I don't know if it's local contracts or quite what it is, but I think we wouldn't want that to be happening in the voluntary sector. We would want to work in a good partnership process with you guys. So if you can let us know exactly, you know, which organisations in what process we're talking about, then we can look into it. So happy to do that, Simon. And I think if you can, if you go directly to Jonathan, I'm sure he would be happy to pick that up. Can I just say something on what Alyssa said? I think on the cancer particularly, I think that particularly on prevention, which I think is the bit where the ICP will have a focus, there will be a work stream, I think, around that kind of area around prevention. I think we can pick it up through that. But I know that Karen, I don't know if I can bring Karen in just to talk about the work on the forward plan that we will be doing for the NHS in partnership, because there will be a section totally on cancer. I don't know if you want to just set that out.
Sure. So just to remind everyone, because it gets a bit complicated, we've got 2 5-year forward looks to develop together. One through the whole of the partnership, through the integrated care partnership, where Ruth chairs that group, and you'll know we did a discussion document which has just closed about what should the whole system be working on together, which is where Sarah's prevention point comes in. And the second is the NHS, so the joint forward plan for the NHS, so the next 5 years for the NHS, and we're in the process of developing that at the moment. I think probably around this group, I've spoken to most people in different meetings about the structure of that document, and one of the chapters we will have will be a cancer chapter, given its significance and importance. And Callie and her team highlighted that this afternoon or this morning for us, didn't they? So there will be a cancer chapter in the NHS element of those 2 strategies, is what we're planning.
Thank you, Callie.
Thanks. So the conversation I had with Susan and Emma and the team RMP was also just flagging some reference to cancer in the ICP strategy, as Alyssa said. So I'm not quite sure where we're landing with this one, because it looked a bit odd not to have it in there in terms of some reference to it, because obviously
I think we can pick it up in the prevention part of the priorities. So I think that particularly for the partnership, I think that the cancer prevention, which we talked about that early diagnosis, and I think that's definitely an area where I think the partnership, it would sit with the partnership priorities set out in the discussion document. So I think we can definitely do that. And I think the wider kind of more NHS focused work that we need to do around cancer, around treatment and so on, and all of our targets, I think that will be picked up in the 5-year NHS plan. So, but I think that big piece of work that we want to do together around prevention, and also the piece that was discussed around the people living with cancer, you know, survivorship and so on, that could also be picked up as part of those priorities in the partnership, I'm sure. So I think we can think about how that feeds in, and there will be specific groups to look at those high level prevention priorities as we go forward, so we can pick up some of that there, Karen.
Thank you. Karen, do you want to come back?
I just wanted to add to that. So Callie, Susan has written with RMP's feedback on the integrated care partnership strategy and made those points. And we're just liaising with her to say, well, what would it look like, and what would a system do in relation to cancer versus the NHS in relation to cancer? So just trying to be really clear about what action needs to happen at which part, and therefore where does it feature in. So the importance of cancer definitely is in both of those documents, and certainly in our minds.
Thanks all.
Great, thank you. So moving on to any other business, which is item 15. Do members of the board have any other business they would like to raise? No. Okay. So before I close the meeting, I've just got one final thing that I need to do. So for those of you that don't know, I think this will be Dr. Gloria Rowland's last meeting. Gloria is our Chief Nursing and Allied Professional Officer and Director for Patient Outcomes, and she will be shortly joining the African Medical Centre of Excellence as the Chief Nursing Officer. What I just wanted to do was, and I'm sure all board members will join me in this, is thank Gloria for her contribution to this board, but also to the Integrated Care Board more generally. I know, Gloria, you will be missed by those around today's virtual table, but I just wanted to make sure that we noted our thanks to you for all of your work and contribution that you have made, and wish you the best of luck in your new role. So thank you very much. And on that basis, we will close the meeting. We now move on to public questions. So because of the need to allow our NHS CEO colleagues to return to their respective hospital sites as soon as possible, we've only been able to take questions from members of the public that were submitted in writing before this meeting. On this occasion, we have not received any such questions. I bet, I hope that members of the public will understand our need to hold this meeting virtually today and the reasons why we've not been able to take live questions on this occasion. We normally do so. However, I do hope that you will be able to join us in person for our next meeting, which will be held on the 17th of May at the Civic Suite in Wandsworth. And I look forward to seeing both board members and members of the public at that meeting. Thank you very much for everybody's contribution today, and see you on the 17th of May. Bye-bye.